So I appreciate you coming, and I, compared to the last session, which was overflowing, I can't compete as well against long COVID, which is as as I take my mask off to give the talk, I think about. Um, this is a talk. Well, first I'll introduce myself again. So I'm Ed Ratner. I'm a geriatrician and have been active with Magic like I don't know since the '90s, um, and work at the university and the VA. And within my career in geriatrics, a couple of topics have kind of been the focus, and one has been home-based care, and the other is advanced care planning and things around that. And so, more recently, working at the VA. I've been working on the topics around the 4Ms, the age-friendly health system, and within that, kind of what matters, and have carried that forward into this talk as well as work for the GWEP, which Dr. Picala talked about. Um, so I was learning objectives, um, kind of understanding what matters is part of age-friendly health systems, and think about how to get answers to the what matters questions. We'll explain what matters is for those of you who aren't familiar. And the third and the motivation for this talk when we were doing in the planning committee was how to actually do this in a financially sustainable way. Because as the last speaker talked about, talking about capacity, the limit on the quality and frequency of doing that is time and clinician or expert time and includes attorneys. I have to say this. Okay, so how many of you are familiar with this slide, age-friendly health system? Okay, pretty much everybody. So I don't know, it's been, I think, 7 years or something, this concept was floated by the Hartford Foundation and the Catholic Health Systems and through the Institute for Health Improvement. And the idea is that health systems have so many things they could do for older people that they're serving that by narrowing it to these four topics for which there is evidence that you can do something about them or that we can standardize some assessments for them, that we could improve care for older people substantially. And it's not everything, and there are problems that don't fit nicely into any of these, but these four represent such a large portion of the problems that we face. And I think it's consistent with the comments in that first talk about robotics, is what would we do with a robot, is these kinds of things are kind of the kinds of things we came up with. So I'm going to focus today on one of those, and the tagline that Institute for Health Improvement uses for what matters is know and align care with older adults' outcome goals and preferences. And so it's a complicated thing, but the know is kind of the assessment, and all four of the 4Ms start with the assumption that we need to assess something. And then aligning care is aligning care not with what we want, but with the outcome goals and preferences. And for those, how many of you were at the session yesterday afternoon? Okay, so most of you. This idea of taking that case study and saying what are the goals as we looked through the care plans that people wrote, most of them were very patient-centric or family-centric in terms of thinking what the patient wanted. And the case study actually said, this is what matters to her. And so it was relatively easy to identify because it was already known what matters to her to develop that care plan. But on the other hand, not all the care plans addressed what matters. And I think that the key to the 4Ms is that you start with the what matters, and then the care plan for the other three is built upon that. And so what medicines they're on is they have to align with what their goals are. The mobility is so they can go where they want to go. And that's kind of a way to think about that. this whole concept actually predates what IHI did to the shared decision making, which seems like really old. But when I go back to some of the early literature on that, the kind of one of the seminal articles only goes back 10 years, although there was the concepts of shared decision making around specific diseases like breast cancer as one of the early examples. So one of the issues is kind of whose job is this? We talked a little about that in a brief presentation I did yesterday in terms of which members of the team, but the when, who, and how is it. This should be included in your thinking and discussions with patients whenever there are options for current care or future care. So where you can anticipate that there's going to be a decision in the future, or you have a decision now. Kind of how important is this problem for us to address at all for you, relative to other problems or other things going on in your life? And on that kind of when, I used the example of Rudy Giuliani when he had decided to run for Senate in New York. And you remember this? He, in the spring before the election, he was diagnosed with prostate cancer. And then the media found out about it, and that was kind of the end of his campaign against Hillary Clinton in that year. And I often thought at that time and since then, if that was based on screening, if he had a PSA or a rectal exam at that point, and it could have been delayed. It's like did he need to be screened as he's starting out the campaign? And we know the pattern is if it was already advanced, it didn't matter. And if it was early, it didn't matter. It could all waited until after November, and his life would have changed, and maybe kind of all kinds of things would have been different. So the who is, and as I said yesterday, pretty much anybody on the healthcare team can have a discussion either within their discipline and their choices being made relative to their part of the care plan, or kind of more broadly to inform the whole team. And kind of the within the kind of medical staff and others in the setting, it's kind of anywhere. And we often think of advanced care planning as that's a primary care, that's an outpatient, that's an annual wellness visit kind of thing. But the what matters discussion should kind of fit into care in kind of all settings where we have opportunities. And the last is that including in the who is it's not just about the patient. In the last talked about the value of having some time with the patient alone to make sure that their decisions aren't being coerced or influenced, but to include the caregivers. And that I think is really obvious to all of us, is a patient can have preferences and thinks that something matters or doesn't. And the common thing is, I never want to go into a nursing home. Okay. How many of you heard that statement? Okay. And then the caregiver is cringing as that's said, because they know that honoring that preference may be an impossibility or an excessive burden, and being in a situation where the doctor carefully writes down that, yes, patient never wants to go to a nursing home, and then where does that leave the family? So kind of including them in this discussion, because they're the ones who often have to actually implement or act on or deliver the care. So the module that I spoke about yesterday, the online module, that there's a link. If you Google the North Star GWEP toolkits, it's the easiest way to find it. I was told to make it an outpatient case, and I wanted it case-based. And the idea is somebody who had been hospitalized and survived life-sustaining treatment in ICU, and left the hospital, moved to a new town, now lives with their daughter, and presents in a doctor's office. And one of the examples of the questions that represents how do you ask what matters? And there is a whole model called patient priorities, where out of Dr. Tenetti's group in Connecticut, is to hire the health technicians to dutifully document the answer to what matters. Another example of that is how many of you use Fairview Health System ever, or have a portal in My Chart in Fairview? Well, if you look, and they have a part of the background information that you can fill out, like your medicines and your contact information and things. They have a What Matters page, and where you can write down how you feel about things. And I've asked Fairview clinicians, anybody ever look at that, or even know about it? And I pretty much had, no, I didn't know that existed. So they don't even have easy access to it. But you can just ask people, but you get things like, my grandchildren are the most important thing to me, or my work, or whatever somebody says. They're rarely actionable when they're not part of a medical discussion that's more directed. So in this case, an example, and in this module that I created, takes about 20 minutes and was designed for learners, but I think it's useful for practicing clinicians too. A question could be, if whatever happened that led you to be hospitalized happens again, how can we handle that better? And so it's a kind of fairly open-ended, but specific to a scenario. And for a lot of chronic illnesses, one can anticipate that heart failure or kind of exacerbation of some problem could happen again, and the risks of the rehospitalization and need for intensive care could happen again. So what I designed was a range of responses. And so the learner in this module is told, say this out loud. So you kind of have this in your head as to how you could ask this. But then they're given, so what would you do if the patient said this or this or this? And they click on that, and then they're asked to then what would you say? So it's very different than much of the communication training that I've been involved with on both the learner and teacher side was purely about how to ask the question and the styles of communication and empathetic communication. But really kind of walking through the conversation as to then how do you respond to a variety of things that may make you uncomfortable that the patient said this. So to that open-ended question, you can imagine responses that I should have gone to the hospital sooner, or I'm never going back to the hospital, or some things in between. And each of those would have a different care plan. So this is kind of the notion as to asking that question open-ended might generate a way to kind of think about how we're going to deal with the situation. And you could see how this could all be designed as a multiple choice to make it easier for patients, even before a clinic visit or kind of the waiting room kind of thing, is to be able to walk through people so so they've thought about it and you know what they want. So these are the 5 questions that I proposed one might ask what matters. And in a variety of settings and patient situations, variations of these or totally different might come up. But you can see how they're about the kind of anticipating a specific type of care, or the second one is more functionally based. What do you want to do, or what do you want to stop doing? The third one I use in my palliative care work as my kind of standard kind of end-of-life discussion in the severely ill patient, and more often with the family of the person who is not unable to respond, and to basically say there are only 3 ranges of things we can do in healthcare. We can help you live as long as possible. We can functionally maybe allow you to do what you want to do, or you can be physically or emotionally comfortable. And the challenge in asking that question and responding to it is that you almost never can do all 3. And you have to prioritize between them. And so the patient who has a hip fracture, who doesn't want to get out of bed because it hurts, okay, is making a choice that I want to be comfortable, so I'm just going to lie here in bed. And then you have to overcome that preference to just be comfortable right now by saying, but this is not the best way to do what you want or live as long as you want in the future. But you probably have all heard of or had patients who actually make that choice. I'm not going to get out of bed, or they potentially don't even choose to have the surgery. They'll say, I'll just lie in bed and take my my chances as to whether this heals up adequately. The fourth one is kind of kind of not the immediate functional kind of thing, but like how are you going to connect with the community, and that has a variety of implications. Um, and then the last one that you may think of as being a social worky kind of thing, I find in a dementia clinic is often the most important advanced care planning discussion is under what circumstances is this living arrangement not going to work anymore? Um, and in this scenario, it just moved in with their daughter, and it might want to kind of move back to where they came from, or might want to live alone in some way. But if you kind of start with that, the rest of the care plan may come with that. And it's not that the job of the types of clinicians that typically come to this meeting, which are providers, are kind of going to plan and do all that. But if you know that that's the direction we're going, you might need to say, oh, then we need to work on your mobility better, because if you're going to go to an assisted living, the kind of building that you have to go down to the dining room, but now you can only just get 20 feet to the bathroom, that's not going to work very well. And so now let's focus on your mobility as a way to turn that into a plan. Okay, so the focus of this talk was on then, with that background, how do we turn this into a billable activity? And let me kind of stop there. Any questions about the what matters and the questions and the way I'm approaching it? Okay. So then the next kind of question to propose to you is how many of you personally or within the group are billing for what matters discussions? Okay. You want to describe briefly, one of you? So, okay. So you're using advanced care planning codes in what setting? Okay. And okay. Okay. So that's I think the most common, but I'm going to talk about some of the other ones and kind of approaches to this. So I mentioned the patient priorities care model, and that they've shown some evidence that you can reduce the number of medications or number of tests ordered by some sort of process of having these kinds of discussions. And this is a national movement, kind of like the Institute for Health Improvement Age-Friendly Health System, where they are exporting it, and you can kind of sign up to be in the network of organizations who are doing this. And so I think we're going to see more of this. And I'm trying to think if Fairview was testing this, or no, the VA. I was thinking who I recently seen. The VA is kind of talking about how to implement this. So I want to kind of start with the just billing in the office. And most of us don't work in office much, but there are implications because some ways that we do things might be office-based, even if we aren't routinely seeing our patients in the office. As most of you know, there's locations of service on Medicare bills. And so there are different codes for the place of service for office versus nursing home versus assisted living / custodial care versus kind of there's a whole list of other kind of sites, and the 99 for kind of those strange sites. And they changed the office coding, in 2021. So we got coming up on 2 years on the change where it used to be you were paid by the word, okay? So the more organ systems you included in the review systems, the more you get paid. And just to share an anecdote about that, my wife went to the doctor with a sore throat, and it didn't get better, so she went back again, and she got billed for like a complex visit. And I said, this doesn't make sense. And the difference for copay for me wasn't much, but it was just like didn't make sense. So I asked for the record and asked for a review as to how did the follow-up visit for a sore throat get to kind of complex level. Said, and then I talked to the person in the billing office, and they said, oh no, we looked at it, and and there were enough organ systems in the physical exam to achieve it. And we went through what those organ systems, it included the gynecological, okay? And what they coded for was the phrase postmenopausal, okay? And they translated that into part of the physical exam that got them wordward. So anyway, so that whole craziness of trying to have templates that, made it 10,000 word outpatient visits so that it had everything, it went away. And now we have these $4 for new and $5 for established. And it's based on basically how much cognitive work you did, and you only need to do as much history and exam as needed to get to that code. But there's also a time-based coding for each of these also. So this is kind of the idea for the moderate complexity and high complexity. These are the high-end codes for the follow-up. You can see that you have to actually do kind of a fair amount in terms of diagnosis and kind of what you worked on to reach these high levels. And these are the amounts you can collect for the amount of time that they estimate is required to do that kind of thing. And I want to show this because the importance of doing documentation of how much time you did, and if your counseling and coordination of care, and as it relates to what matters, the counseling would represent this. So if you're doing a visit that counts as an office-based visit, if you spend enough time in that counseling and you document it, you can use these codes and you can see how much you can bill for that. And that has implications because having this discussion, it could appropriately be not under the advanced care planning, but under just the visit, or it could be both. If you kind of have some activities related to one and something else and kind of combine all that. So think about how to do that in the outpatient setting. And the other time-based codes for the E&M visits, which they only changed the documentation requirements for the organ system stuff for office. So these other sites, there's still an expectation you're doing a certain amount of documentation, but you can see the amount of minutes and the money. Unfortunately, the home-based visits are way kind of under priced relative to the time it takes not only to do the work in the home, but to get there. And one of the challenges has been Medicare never recognized that we have to get to the home and that that's part of the work, and that there's no way around that right now. Okay. Any kind of question about the office dates? We're going to come back to that because some work represents office-based because if you do telehealth from your office to a caregiver, that's an office-based code. Even if the patient has always been seen at home or a nursing home, if you do the work from the office, then you have to bill office. That make sense? Okay, so advanced care planning code, and this, some of you mentioned you do use this billing. The definition is that you discuss advanced directives using some form, but it doesn't require that the forms be completed. And so kind of mentioning that this is kind of included in what we're trying to talk about and we can document this meets kind of these standards. So it's not just about filling out the form. And there's a code for it, and there's a essentially prolonged code, so you can bill more for each additional 30 minutes. As I understand it, and from reading several places, unlike the care plan oversight, which we'll talk about in a minute, this first 30 minutes doesn't mean you have to spend at least 30 minutes. Is several of the resources I read said the definition of 30 minutes here is 16 to 46 minutes. Is that the general understanding? Okay. So, and then if you go back past the 46, then you have another 30 minutes that represents a 99498. So these are our RVUs and the dollar amounts that I could find, and I didn't verify that from explanation of benefits or something, but it's in the ballpark, and from the CMS site, what they cited. So you can see how, bottom line is, you can pay a non-physician at these rates, and you could pay a physician if you didn't have any overhead. But if you have overhead, like all other cognitive work, you can't generate enough revenue if only half of the money goes toward the provider and the other half has to go to the institution for overhead. So that's kind of one of the challenges. So one of the keys to this, this is a actually slide about the use of advanced care planning coding from an article just this year. And this was an article about a variety of codes that could or should be used in care of patients, like advanced care planning, but include like issues around obesity and weight loss was another set of codes. So 100%, there's no criteria of illness or diagnosis for advanced care planning. Every Medicare beneficiary is entitled to advanced care planning coding. In this study, in a very large sample, only 22% of patients were having advanced care planning codes built. Or no, 22%, and this wasn't from actually review a study, this is from the literature. They find evidence that about a quarter of people have some advanced care planning performed, but only 4% of the patients had it billed. So a tremendous opportunity for some incremental revenue to your practices if you're kind of at that low end, obviously. And just kind of figuring out who's going to do it and when and how. So kind of some of these tips, I mentioned that it can be added on to other E&M codes. So if you do this advanced care planning for at least the 16 minutes, in addition to the history and physical or anything else you do, you can bill for the E&M code and this. And there aren't that many codes or situations where you get those opportunities to essentially kind of have add-ons. It's like the waitress that wants you to order dessert so she can get a bigger tip. This is just a good thing to do. It can be used in any setting of care. So the advanced care planning billing is allowed in the hospital, for example. So you see patients on rounds in the hospital. How can and should somebody go through, an older person go through a hospitalization and have the provider never spend 16 minutes talking about kind of the future and mentioning advanced care planning? Or I looked at your healthcare directive, and is this still what you want? As part of a discussion, you think over a course of a 5-day hospitalization, the hospitalist is probably spending 3-4 hours with the patient and the paperwork associated in terms of number of patients they're doing encounters with in a day. So an example of a setting that we may not be using that optimally. Under the current COVID rules, we can do audio phone calls and do advanced care planning billing, okay? And it doesn't have to be with the patient. If it's not with the patient, you have to document why the patient is included, but many of the kinds of patients we see in long-term care settings, for example, might not be able to actually have this discussion. So it's not about the form, it's about the advanced care planning. And so calling the family members from the office setting on an annual basis to kind of talk about, here's kind of what I know about the advanced care planning, and I just want to confirm this. That is kind of allowed just a telephone, at least as long as the COVID rules apply. Anybody doing anything like that now? Okay. And on top of that, in the office setting, uniquely, because you can't do this in the hospital, the provider doesn't have to do it. So we're talking about the provider's time is too valuable doing other things, but in the office setting, you can have anybody do it. Doesn't even have to be a licensed professional. It has to be somebody professionally trained to have these conversations. And the incident 2 rules mean that a provider has to be in the office at the same time. Doesn't have to be the provider who's caring for that patient. And the rules explicitly describe how in a group practice, it might be somebody else who's doing the supervision, but they have to be physically in the office at that time. So as an approach in a long-term care practice, assisted living and nursing home, for the patients who can't have these conversations themselves because of advanced illness and cognitive problems, for example, is to just put it on somebody's job description to call every kind of emergency contact proxy annually and have these conversations and bill. The other kind of issue is it's not limited how often you do this, but if you're doing it more than annually, you should document kind of why you're doing it again. But in our practices, these things come up many times a year. Patients has a change in condition. So think about in terms of after any ER or hospitalization, there's a change of condition that justifies having another conversation to see kind of where things are at. And it goes back to that what matters question is like, so if that happens again, what are we going to do this time? And that example from long-term care settings is, so now, your mom's been in the ER 3 times in the past 2 months. If she falls again, what could we do different? And kind of how are we going to document that as a preference? The last item is it has to be voluntary. And so you want to make sure you're having that discussion and documenting that that you aren't just soliciting this work because in part because there's a copay and so some patients who don't have full coverage might have out-of-pocket expenses. So you're not supposed to just like make people do this. The copay doesn't apply. Let me see if the copay doesn't apply during an annual wellness visit. And how many of you are doing annual wellness visits for your patients? Okay. So annual wellness visit, there's a whole kind of template of things you're supposed to cover. It's really designed for the well older person, but it can be used in other settings. And the advanced care planning can be billed in addition to the annual wellness visit code as a separate code. And if it's kind of on that same day associated with an annual wellness visit, there is not a copay. And so there's a process to do that documentation. Okay, so I want to go back to ideas, and I mentioned is having somebody in your practice do these kind of outreach visits to the families of long-term care patients. And you do want to use a GT modifier for the incident 2. I mentioned the annual wellness and kind of that updating the post. And so it's not a healthcare directive, but it's an advanced directive plan as the post is the tool that we use in Minnesota. And so updating that when there's a change after a hospitalization or an ER visit. And then the other kind of thing is thinking about the video visits that could be done with on a schedule basis with families and how valuable that could be and how you're going to pay for that essentially is thinking about this being a part of that process and tool to have these discussions and justify those essentially provider level discussions comparable to the quarterly care planning meeting that families are invited to in nursing homes, but they don't occur at all in that same fashion in assisted living, for example. Care plan oversight. How many of you are using care plan oversight? Okay, so not many. So this is I was kind of part of the team with the American Academy of Home Care Physicians that advocated for this and advocated for changes in the rules to make this actually feasible. It's not easy, but it's a great way to do something that you don't want to do yourself, but want to order somebody else to do. So in all the cases where we can order skilled home care or hospice, okay, there is a billing code for doing the paperwork and talking to the agency, okay? And it's complicated in terms of the documentation, but my sense is that, we don't do this at the VA, but there are tools within some EMRs to make this easier. And the idea is, if you do, and this is not a fraction of 30 minutes, if you do at least 30 minutes in a calendar month of this care plan oversight, Medicare will pay you. You can see it's the GO codes, the second and fourth lines of the Medicare codes. The other lines are the non-Medicare CPT codes that may or may not be paid by the Medicare Advantage plans. Anybody know? It's one of those questions that unless you do it, you don't know if it works. But if you bill Blue Cross Medicare Advantage for a Medicare patient and you use the 99374, will you get paid? And maybe not. And it depends on how they're doing their coding at their end and accepting bills. But if they haven't differentiated between their Medicare Advantage and their other types of patients, these are codes that non-Medicare younger patients, commercially insured patients, these codes exist and are payable. So you have to have some mechanism of tracking adding up to the 30 minutes per month. But if you think about if you and you don't have to do it down to the second. Okay, when I was doing this, I had a template that had 10-minute increments. So anything I did was 10 minutes. And you think attorneys do, if you do anything, an attorney has a 10 or 15-minute increment in terms of what they say. It takes them 1 minute, they still bill for 10 minutes. It's like, how do you do something for kind of, if you're going to track? So that's kind of the approach I always took. And so if signing that form, that 485, or the hospice form, is every time you get one of those forms, every time you get an order and have to sign it and put them back in the box, is most home health referrals for skilled care and all hospices require this amount of time if you're actively engaged at all, because there's enough paperwork and one phone call to the agency per month to talk to them, or receiving a call from them, gets you. If they're complicated enough, they're calling you, then you're going to get to those 30 minutes. But you have to count the typically 2 or 3 things that happened that month to count it. And the connection I make to the what matters is, if you want to have somebody do this essentially on your behalf, home health nurses and social workers and hospice staff are really good at this, and this is part of their work. And figuring out how to keep people at home is part of their job. So saying, this is how I'm going to get it done. And assisted living patients are eligible for skilled home care. You change any medicine for a frail person, and you want to monitor whether they're actually taking it, whether they're having side effects, or you discontinue medicine. You want to make sure they're doing okay. There's a lot of circumstances that, even in assisted living, that nursing staff isn't going to contact you and monitor as carefully as you want, that you can order a skilled home care referral and they make a couple visits. They collect for the episode and you can bill for the care plan oversight. And Medicare, compared to kind of what the proceduralists are being paid for in terms of if you have an endoscopy or any kind of minor surgery, dermatology, something, they're paid vast amounts by the same insurers to do their little procedures. Don't feel it's cheating to kind of do what the patients really need. And these kind of things like the home care rules, who's eligible, and the care plan oversight were designed to incentivize us to actually put in the orders when appropriate and to oversee that care. Chronic care coordination billing could include the what matters discussions, advanced care planning kind of things. And so think about that for that population if your group is doing that. And that's not just the clinician, the provider, that's kind of the whole clinical team. There's transitional care codes that might relate to this topic also. And I just want to comment on other approaches to thinking about how you get advanced, what matters questions answered. I have 2 grown daughters. One's a hospital chaplain and the other's a hospital dietitian, both at Fairview. And I've come to learn through their training and now their work kind of how much of this stuff they do. And so actually putting in a referral for a chaplain in the hospital setting, and some nursing homes have chaplains routinely. And even for the community or assisted living, is thinking about asking people, so what parish are you in? Or what, what church or synagogue do you go to? And do they know kind of, are you still in contact with them? Would you want me to let them know that you're here? Would you like any spiritual care? Is many faith communities, and it may not be the clergy person, but many faith communities have friendly visiting volunteers or actually nurses. The parish nursing kind of model is across things. So thinking about how you get somebody from the faith community to visit somebody, and these are the kinds of discussions, what matters, that people, chaplains and people doing faith community outreach often have with people. And then the question is, how do you get that information back? It may be it's a opportunity for the patient to think about these things, and the next time you see them, you say, so what did you guys talk about? Or it's much easier to have these discussions if they've had them with somebody else previously. Similarly, all the kinds of facilities have access to some level of social work, and making those referrals and putting it specifically, could you have a discussion around kind of what's the person's most important goals and what are we most trying to achieve here, and have a more lengthy discussion than you might be able to have. And I mentioned the online tools, MyChart, and I kind of have the screenshot of what that looks like from the mHealth. There's a new organization that I just came across in the newspaper, UzoBinc.com. It's Uzobi. Anybody heard of this before? So it's a local organization that has a business of providing online tools to document essentially what matters. It's not just the Advanced Care Directive. You're saying you've heard of this, or? Okay. Yeah. Yes. So. Right. A good place. Yes. Yeah. So this company has a couple of products and different prices, and it's a fairly new company. That's why I was in the newspaper kind of describing it. But they charge somewhere, I think, between $50 and $100 to the individual, and I think their business model is to try to sell this as a package to health systems or insurers or somebody to pay for it for kind of their people. But the idea is an assisted tool with not just some questions, but some whole kind of discussion models, so you can document these things. And then the other challenge with these online tools, and the other one is mydirectives.com, where you can fill out a healthcare directive, but it's a more advanced complicated decision-supported healthcare directive than kind of the type of forms that we're normally using on paper. But what's interesting, mydirectives.com is free, and it allows you to use the same technology that when you deposit a check in the bank. So you can take picture of each page of your healthcare directive if you filled it out on paper and upload it to their site. And then the URL can be made available to people, or you can email a link, the same as kind of a Google Doc link kind of thing, to anyone you want, including your healthcare organization. And theoretically, Allina or Mayo or a doctor's office could receive that email and interface it directly into their healthcare into their electronic medical record. At worst, you print it off and scan it back into the record, but it's an electronic kind of tool. So those are some directions things are going to help people do what matters. And if it really comes down to you don't want to do it and you don't have the manpower, and even if you could bill for it, it's not what you want to do. It's kind of referring people to essentially somewhere else that they can do it efficiently, because it's not so easy to find somebody to hire. And the last discussion in terms of the attorneys, there are a tiny number of attorneys that are qualified to have the discussion versus kind of have a template that everybody gets the same healthcare directive language. So in summary, figuring out what matters should be routine, and kind of it kind of variety of settings, situations, and team members that might do this. They count toward time-based billing, and there's a variety of time-based, and we talked about care plan oversight and the other codes. And I think that it's reasonable to try to move that 4% kind of in our community up much higher, to have some documentation that we did this. And I think if you went back to your institutions and said, I have an idea for a quality improvement project, okay, that will pay for itself, okay, and our measure won't require chart reviews or a lot of work. We're going to measure the success of this quality improvement project by seeing how many ACP billing codes we generate this year, and as a proxy for that the work was done. And then figure out how you're going to kind of do the process between kind of saying, here's the idea, and getting all these codes built. So the training again, there's the module that I created, and then ACP has an online tool on the patient priorities care learning modules, and some references. And these slide sets should be on the CME website that you reference. So questions? I think we have, do we have any minutes left? No. But since we've run over and everything else, I'll take a couple questions. So the question is, can a primary care provider bill for advanced care planning while the patient's in the hospital if they're not the hospitalist? And I would say that if the carrier were really sophisticated and had ways to kick that out and know that that patient's in the hospital, so how can there be an outpatient code? It's possible that might be kicked out. But since an inpatient in the hospital can simultaneously go to an outpatient visit, and there are circumstances where hospitalized patients are sent to an outpatient clinic for something, and it's not included in the hospital bill, that the carriers might receive simultaneously for the same day a hospital visit code and a outpatient code, but they would be different providers. So a hospitalist wouldn't be able to do this, but I think that would be an appropriate work for a primary care, and particularly kind of our kinds of long-term care type of practices, where we actually know the patients and know their preferences, and to work collaboratively. So for the hospitalist to contract, not financially, but to say our relationship with Twin Cities Physicians or Genevieve or something is to have them have these discussions, because we don't have time, we don't know the family, we don't even know who to call. We don't have that number in our charts. That would make sense to do. But I can't guarantee that the carriers are going to cover it. Okay, we're going to, yeah. One more question and we're done. No more questions. Okay, I'll stay around if somebody has some.